Hello.
Welcome to Lina
and Rada's show. Hope you're doing well. We are very happy to run this show today for you.
Definitely.
So it's a recorded one.
Yes, we are trying to record some episodes of our show just in case we move to stage 4 and we are no longer able to do it live. But either way, we want to keep connecting with you guys, so that's why we are doing all these recordings for you. So previously, we have had the first recording about the oral mucosal diseases, and we spoke a little bit about all the changes and trying of making a comparison between the old TG and the new TG. So today, we are going to go ahead with the rest of that chapter, just to finish all the comparison and spotting the changes that we have there. Remember, we are not live, but that doesn't mean that you cannot ask questions.
Exactly.
So in the moment that you are seeing this video, you can leave your comments in the comment box, and definitely we can answer your queries or your questions if we are able to do it, of course, because we don't know everything. You know. But we try.
Never know. Nowadays in Melbourne, everything is uncertain.
Yes, it is. So many cases, face mask regulations in place right now. So I hope you guys are, keeping the face mask near to you just to be safe, and to take care of your families and your friends as well.
If you are in Victoria.
Oh, if you're in Victoria, yeah, that's true, because I work in Geelong a couple of days and they are technically not in lockdown. Melbourne is the only area of Victoria that is in the lockdown and with the mandatory rule of using the face mask.
And the northern suburbs.
Yes.
Otherwise, we have also other candidates that are from other countries or from other states in Australia.
Yeah.
So just stay safe.
Yeah, definitely.
So,
Okay, Rada. So when was
now our first topic will be about mucous membrane pemphigoid.
Yes.
So in the old TG, they mentioned a chapter for mucous membrane pemphigoid and a paragraph, and a special one for pemphigus vulgaris.
Yes.
So here they talked only about MMP, but pemphigus you have to check the E version of TG. Otherwise, nothing new.
Yeah, nothing
it's
new.
Pretty much
You
the
have
same.
probably a new photo there that is showing you how it will look like. But as you guys can see, it's very hard to make a differentiation of something like this just by looking at a photo, because basically when you look at it and you see all that plaque and all that ulceration or inflammation, you think lots of things before your mind goes exactly to mucous membrane pemphigoid. But I think it is important because if they are adding these new things, probably it's because they are seeing a more common prevalence of these lesions in the population, and that's why they are bringing this to the new TG. So I think when you see the clinical photo and you see that this is associated with mucous membrane pemphigoid, but if you look at it, it looks like a regular gingivitis. It could be also necrotizing gingivitis. So maybe this is a hint for you guys when you are seeing a particular clinical case or OSCE, that has this kind of presentation. That's one of the things that you need to keep in mind
to make a differential diagnosis. So maybe what we can spot in this picture is that it affects also the attached gingiva.
Correct.
So maybe what we can do is cleaning, and if we see that it's affecting the attached gingiva, we can refer to a specialist, because as you can see here, we need a biopsy to make a differential diagnosis between pemphigus vulgaris or MMP or something else.
Yes, definitely. So if the patient doesn't respond to a local therapy, such as a scale and clean, and then you need to reassess your options in there. That's why it's quite important for you guys to keep in mind all the variety of possible presentations that are similar within each other, so you can know how to direct your questions for an information gathering case, for example, which is a typical case when you will need a differential diagnosis.
Exactly. So here we're going to move on to oral candidiasis and the candida associated lesions. So what we could see is that they really organized this paragraph, like this sub-chapter.
Yep.
They organized it with different tables with the clinical features, the factors the risk factors or predisposing factors, and the management, and a little picture to help you to understand and see how it looks. So I think this is really well made.
This is very useful,
very
good because it's super clear. As Rada said, basically there's a lot of presentations inside of the mouth that can be associated with candida.
Yeah.
So they have said here, okay, the lesions that are associated with candida are the following: pseudomembranous candidosis, erythematous candidosis, hyperplastic candidosis, angular cheilitis, denture-associated erythematous stomatitis or denture stomatitis, and median rhomboid glossitis. Which is new. It wasn't mentioned in the old TG. Again, this could be a hint that we are seeing a lot of prevalence of this particular lesion in the population, and that's why they brought this to the new version. So I think in here it's very important for you to understand that all these lesions are associated with candida. The name basically varies depending on the origin or the cause, and also in the part of the mouth that you can see this presentation.
And also the color, if you can, for instance, the pseudomembranous candidiasis, if you take a gauze and you could remove this white thrust, this is different from erythematous candidiasis, which doesn't show any white thrust, or you can't rub it and remove it with a gauze. So it's really well explained. I think you can't have any problem, or and we studied that also in part 1 for the written exam.
Yeah.
So
yeah, I think that's going to be very useful, not only for part 2 but only for part 1. And here it's very important, for example, erythematous candidosis. How are you going to differentiate that from denture stomatitis, for example? Because both of them, have this red inflamed area. So here you go to the possible characteristics, the possible management, the predisposing factors or causes. So I think this is pretty much like hints for you. You see something in an OSCE, and then you are going to extrapolate everything that you have in this chapter to that particular case, because we know that we have cases about angular cheilitis and denture stomatitis. So if you know that there are several OSCEs that are touching these two subjects, then you go in there and you, for example, if you have angular cheilitis and you see that the predisposing factors includes, dermatitis, that's something that you want to ask in the medical history of the patient, for example. So it's just to structure your case very, very well, so you can establish also a good differential diagnosis if needed.
exactly.
Yeah, I think that's pretty much it. So they have described first all the possible lesions associated with candida, and then
Then the treatment.
the management or the therapy. It is described and differentiated as well. So in antifungal therapy, what do we have new? Right?
So the difference between the old TG and the new one is that we have a treatment for neonates and children below 2 years old, and a treatment for those that are older than 2 years old and adults, because they say that it's an opportunistic infection. So when you have predisposing factors like an immunocompromised condition, you are more likely to develop this candidiasis. But also in very young children, neonates, it's very common to have, and parents, they can tell that yes, it is. So the other thing is that they removed also the interaction between warfarin and miconazole. Which is
weird. Yeah, because in the old one they said that Mucosal can interact with warfarin and can increase the value of the INR. So
we were thinking that maybe it's not that
significant.
It was significant because when you swallow a very small amount of Mucosal, I mean, how much goes in the bloodstream?
Yeah, probably it's not significant for these purposes.
Maybe that's why they removed it.
Yeah.
Something else about nystatin, they mentioned that it contains sucrose, so this you have to consider it for maybe your caries risk.
Yep.
If patient has a high caries risk, maybe we would avoid this option.
Yeah, because we know here that, for example, poor oral hygiene can be a possible cause or risk factor for candidosis. So if a patient already has a poor oral hygiene and we are putting nystatin in there, if we are talking about, let's say, children younger than 2 years old, the possibility of them developing caries is higher. So probably either you switch to Mucosal just to eliminate that probable risk, or you are going to establish a very well monitored oral hygiene regimen for these patients, so you know that you are not removing one problem but then causing another one because of the sucrose content of the nystatin.
Other than that, for angular cheilitis, they added clotrimazole as a topical antifungal. They added hydrocortisone, so a mild corticosteroid, as a topical antifungal if you have an associated inflammatory dermatitis. In the old TG, you could combine the treatment of the general candidiasis with the angular cheilitis, which is not the case anymore here.
Yeah.
You have two separate, two
therapies.
different treatment for each condition.
Yeah, true. And I think also for angular cheilitis, I think it's pretty much the same. Some changes, in the criteria to choose the antifungal therapy. For example, for oral candidosis, they mention first amphotericin. Now that amphotericin is coming into a second place. So, basically it's up to you, but minor changes just to keep in mind there.
Exactly.
I think that's pretty
much the same. Now oral mucositis.
Yep.
I think it's the same as well. Just they developed a bit more about the management. For instance, they added the nutritional support for these patients. That it's very important. And you have to avoid irritant food, spicy food, and stuff, acidic food and stuff like that. That you have to refer them to a specialist, like nutritionist.
I think that's pretty much it. Remember that everything that comes that is new, you need to establish why it is mentioned there. So, for example, they have highlighted the nutritional support as one important part of the management if you spot a patient that has oral mucositis. And that's basically because if the patient has a generalized pain and it is very, very painful and tender, it's difficult for the patients to eat. Therefore, they can have deficiencies, in the nutritional values. Therefore, they are more at risk of developing candidosis, for example. That is going to be a superimposition over the oral mucositis. So everything has a link, and what you need to do when you are reading this, more than memorize it, is analyze it to see how you are going to incorporate this in a particular OSCE. I think that's quite important.
How to link
Exactly. So here I think regarding the management of oral mucositis, they have mentioned here benzyramine and lidocaine, which wasn't specifically established in the OTG, but this is pretty standard as well. And obviously, we want, if the patient cannot eat, probably the patient cannot brush their teeth properly, and oral hygiene is going to be neglected. So here is a combination of control the pain with the analgesic mouth solutions, oral hygiene with chlorhexidine, plus the nutritional support. So all these three things goes together, and that wasn't mentioned in the OTG. OTG was more about like, if you have a dry mouth, then you do the same thing that you would do for a dry mouth. So here it's a combination, it's properly a management more than a treatment, you know, because you are considering the entire social effect of this oral mucositis. So don't forget, analgesic, oral hygiene, plus nutritional support.
Correct.
Then dry mouth. Same, yeah. I mean, they describe the medications associated with dry mouth. I think they are putting a couple more of medications than we saw in the last one.
Muscarinic antagonist.
Yes.
For the inhaled bronchodilator.
Exactly. And in the management, basically it's the same as well. You see box 14, which is the practical advice for patients with dry mouth, which is pretty much the same that you had in the OTG.
Yes.
So I think that one is also pretty much covered. Yeah, I think that's pretty much, dry mouth doesn't have too many changes. Yeah, that's okay.
Now, next chapter, halitosis. Same, we didn't spotted many differences. Just a bit more extraoral causes.
Yep.
So you have to go through these conditions. What they added more, they detailed a little bit more about the management, but nothing out of the box.
Yes. It's just that they are trying to organize more everything.
Yeah.
So nothing is just, up in the air. So the management is just, enunciated in bullet points, so we don't forget anything, like oral hygiene, odor-causing foods, mouth breathing if it's identified in the patient, and obviously what thing that you can add to that management.
Stimulation of
saliva, yes.
Hydration, reduce the caffeine intake. They are saying also if there is extraoral cause of halitosis, so we have to refer. If the patient has persistent or recurrent halitosis, again, referral to our oral medicine specialist or periodontist. If the patient has psychogenic halitosis, which could be the cause. So again, maybe a psychological referral, and at our level as GPs, we can just reassure, because it's quite challenging to reassure this patient that have imaginary
halitosis.
Yeah.
And basically here is, the frontline management for this is try to establish any intraoral causes for halitosis. So basically, as dentists, this is our role, Let's tackle first that, what is happening inside of the mouth.
And eliminate the dental cause.
If that doesn't work, then we need to refer.
Yeah,
exactly. So that's basically the message to take. When you see the causes, this is not that we are going to diagnose the patient with any particular extraoral cause. But if the patient has the disease, probably the patient knows. And if the patient tells you, then you can tell the patient and reassure the patient that could be, like a secondary effect of the medication, or even of the disease that the patient has. Therefore, you control intraoral things, but then you refer in order to see if the GP can help them with this.
Exactly. That's pretty much.
Yeah. That is pretty much. And I think that's quite what we have. The next chapter is going to be about orofacial pain, but this is pretty much everything regarding the
changes between old and UTG, the differences. That was
I think that's quick. That was quick. So basically, with this session and the one before, we have done an analysis of oral mucosal diseases chapter, which is, I think, one of the chapter that had more changes, right?
Yes, exactly.
Yeah, but changes are good because some people are like, oh, they changed this, now I need to memorize more things. And yes and no. I mean, you need to read a little bit more, but also everything is very well explained.
Yes.
So I think it's going to be useful for the candidates when they...
even easier to memorize. It is clearer as well.
Yes. I think the old chapter was more,
a lot of
subjected to interpretation.
Yeah.
Like maybe it says this, maybe it says that. This one is like there's no room for interpretation. This is the management. This is what you do if a patient
have a picture.
Exactly. So it's quite straightforward, which is something that we like definitely. So don't forget to leave your questions regarding this episode today. If you have any confusing things that we have said that you need to clear, just submit the question to us, and we will take the time to revise everything and probably come back with a good solution for you about that query.
So this is the end of our show. Take care and see you next time. Bye.